Welcome to today's eLotus webinar, your leading source for acupuncture continuing education. My name is Donna Chow, and I will be your host and your moderator for today's class. This course is titled An Overview of Current Western Medical Practices in Clinical Oncology, Implications for TCM Practitioners. It's sponsored by Evergreen Herbs and presented by Dr. Shu-Hong Luo. This class will be from 8 a.m. to 5 p.m. Pacific time, and we're going to have 4 short breaks throughout the day, and lunch is scheduled from 12 to 1 p.m. So before we get started, let's ensure an interactive session by setting your chat preference to everyone so that all attendees can see what you're writing and your text will be public. For instructor questions, please use the Q&A box. Our instructor today, Dr. Luo, received a comprehensive medical training in both Eastern and Western medicine before relocating to the U.S. From 1986 to 2006, Dr. Luo held the esteemed position of Chief in Hematology and Oncology Division at St. Mary Hospital in New Jersey. He currently is practicing in New Jersey, and so let's go ahead and welcome Dr. Luo and dive into the session.
Okay, good morning, everybody. I'm Dr. Luo. I'm in New Jersey, which is 3 hours ahead of you guys in Pacific area. And I'm very happy to be here today, and thanks to Lotus Institute giving me this opportunity to present our Western oncology practices, which I believe will be helpful to TCM practitioners. And as a matter of fact, Tina has asked me to do some to give this presentation years ago. However, due to different reasons, I didn't do it until past 3 years. And my younger daughter, who attended TCM school, and through her, I got to know how much Western medicine has been taught in school. And also, I feel that I could be helpful to add some more Western medicine to TCM practitioner. And so actually, I volunteer myself after so many years. I volunteer myself to Tina, ask her to give me opportunity to give a talk about oncology, cancer management. Because through years, I have few contacts with different people, and I understand TCM practitioner may not be so familiarized with oncology, cancer management. So I like to take this opportunity to introduce to you. Hopefully, by understanding this cancer in different aspects will help you to understand cancer for your future care for the patient that you may encounter, especially those with cancer. And many times people ask me, why do I stop practicing oncology and jump into acupuncture, Chinese medicine? And some people may be kind of curious as to, well, what happened? They think I may have Judy's story. However, no. The reason why I changed my course in my medical practices, it was during Western medical oncology practice, I found some difficulties. So I decided to use acupuncture to help my patients, which I have studied in Taiwan in 1970s. And time went on, and acupuncture became more popular in this country. So gradually, I decided to leave Western medicine, mainly oncology, because oncology practice is really quite boring. And I like to take the new challenge, which is traditional Chinese medicine. So here I am. Okay, now this is my brief introduction to myself and the reason why I do this presentation. Again, I like to emphasize, I'm in no position to teach you guys TCM because I know you guys know better than me. However, I just like to share with you how to look at cancer from Western perspectives, which I believe that will help you to understand management in the future. And also during my presentation, I'll blend in Western and Eastern, try to integrate these two systems so can provide better care to all our patients. And sometimes in my practice, I notice there's a conflict between East and West. I understand that. And for example, last year, I attended American Academy of Medical Acupuncture, which is mainly medical doctor who practice acupuncture. During one of the sessions where there were panelists up there to answer questions to the audience, and I was one of the audience. Now, there's one person asked the panelists how to manage menopause. And apparently the answer was not satisfactory to the audience, to the person who asked the question. And she felt frustrated that she couldn't be helped. So I raised my point to the panelist. I said that one can try Chinese herb. To my surprise, one of the panelists, supposed to be a leader, said outright that Chinese herb doesn't work for menopause because she had tried one, it didn't work. And then really, I was very unhappy with that response. So I said to the person, the panelist, I said, if you use the right herb and you know how to use it, it will work. Apparently, you use the wrong one or somebody who gave you advice is not competent. And I was very unhappy about that. From the incident, it shows that even the doctor, Western doctor who practiced acupuncture had the misconception about herbs that only out from ignorance, which is totally unjust and also unfair to the patient that she may have to help in the future, because she shut the door for the patient who may be benefited by using Chinese herb. So, on the other hand, in TCM area, I also heard that many times my patient told me that her acupuncturist told her not to get chemotherapy, which I think is absolutely unnecessary. On the other hand, it's the same as if Western doctor against Chinese herb and Chinese doctor against chemotherapy or Western medicine, which is not right. Because in my practice, I've seen that I treated person with lymphoma, the size of a lemon around the neck, which shrunk in 4 days after my chemotherapy. And also I've seen numerous cases, chemotherapy helped in treating breast cancer, colon cancer, and so etc. So it is not fair for anybody to tell patient not to get chemotherapy, which may be helpful. Of course, some may not be helpful. However, I think we should all keep an open mind to use both, to integrate both West and East. Whichever is useful, I think we should try to help patient instead of being decision maker for patient not to do this or not to do that. And that's my opening statement. I hope you understand where I'm coming from. Today, basically, I'm going to integrate. And during my presentation, I may use Chinese medicine to explain Western medicine, or using Western medicine to validate the TCM theory. Okay, here we go. And as what Donna suggested, we're going to have 1 hour and 15 minutes for the first session, followed by 15 minutes break. And then the second session, same time, 1 hour and 15 minutes. And the third session will be 1 hour. And then I try to stick to the time schedule. And 12 o'clock Pacific time will be our lunch time. Okay, let's go. I'm going to share the first slide. Okay, now let's talk. What is cancer? As I said, abnormal cell that grows uncontrollably and has the ability to invade or destroy normal body tissue. It's usually caused by altered or mutated genes. Now, the key words here is that please pay attention to uncontrollably and destroy normal tissue. And it's caused by altered and mutated genes. The message here is very clear. Why is it uncontrollably? Because our body, in every part of the body, every control, the cell, normal cell should have its own lifespan. It comes out and goes away. Okay, for example, which I'll explain later. Red blood cell has lifespan 120 days. White blood cell 12 to 17 days lifespan, and a platelet 7 to 12 days. That means when these cells that come out from bone marrow, it will die after a certain time, and it will go be absorbed in the spleen. So all the cells have lifespan. And cancer cell, why cancer cell so deadly is because it does not stop growing and keep growing. And another benign condition, abnormal growth, will be, let's say, birthmark, which is not continuous growing. It just goes to a certain extent, it stops. And again, another message here is mutated gene, altered mutated gene. So it means that cancer is not a disease, contracted disease or illness. Cancer represents a body, our body, for some reason, just produce wrong cells that cannot be stopped. And also, one step further, these cells will go to invade other organs and stop, interrupt other organs' function. And that's what cancer is all about. So this is the concept of cancer cell. Now, this slide shows that a lot of causes has been identified to cause cancer. For example, lifestyle is talking about smoking cigarettes. We all know that very well. It's established understanding, a theory that cigarette smoking causes cancer. However, on the other hand, you also see that some people smoke cigarette but doesn't get lung cancer. That's a different story. However, it's established. Number two, family history. Familial polyposis coli is a condition that in family, a person has a lot of polyps in the colon all over, and it's numerous small polyps. I've seen one in my practice. There's a family of 4 boys, 4 sons, and range from late 20s to 30s. And out of 4, 3 had colon cancer. And thank God it's an early stage, and that's a good case I'll never forget. Now, third one established theories of genetic inheritance of disorders. And most outstanding example will be breast cancer, BRCA1, and that is established. However, BRCA1 only consists of about 10% of breast cancer in altogether. In other words, 90% of breast cancer is not caused by genetic transmission, which we'll discuss later on when it comes to breast cancer section. Now, exposure to certain viruses. Yes, I don't know how familiar with you guys with this. However, I can share with you HPV, which is a human papillomavirus, and which is sexually transmitted disease, and HIV. We all know what HIV is all about. And in HPV, that's linked with cervical cancer, and HIV is known to have Kaposi sarcoma. And these 2 cases I've seen in my practice numerous times, and that's established. Now, environmental exposure, and we'll know that asbestos and pesticides is a well-known example. Asbestos is known to cause lung cancer, which specifically mesothelioma, which is a cancer of the pleural, meaning lining of the lungs. And pesticides can cause some of the disease, cancer formation, and sometimes you can see they call it linked with leukemias. And some high dose of chemotherapy or radiation. Now, this is something in oncology practice we see every now and then. For example, chemotherapy. Most commonly we see in person who receive chemotherapy at a younger age. Let's say, for example, Hodgkin disease, which usually happens in younger person. And usually the treatment for Hodgkin disease is very intense chemotherapy. And they responded very well, actually. However, some of them down the line in their life, they have a secondary cancer, we call secondary malignancy, which is not uncommonly seen. Every now and then we see that. Now, I have this Chernobyl disaster. I don't know if you guys heard of that. That was happened in 1986, happened in Soviet Union, which now is Ukraine, northern part of Ukraine. And the nuclear reactor power plant exploded, and that caused disaster. And actually, according to WHO, which is World Health Organization, they have statistics which showed there were 9,000 cancer-related fatality from that explosion. And as a matter of fact, I happened to see a patient in 1987. He's a young man from upstate New York, and he came to me present with lymph node around the neck, which is obviously lymphoma, biopsy-proven lymphoma. And his story was quite typical of that. He said he was in Chernobyl area shortly after disaster happened. What happened was that in the beginning after that explosion, and it was limited to only 30 miles radius to restrict the area. And then it increased to 100 miles radius. Probably this person went into early stage, which was not considered safe. However, he went in And that was a good one example of a radiation exposure. Now, it comes to radiation exposure. Many times patients will ask me, oh, I have CAT scan, PET scan, this and that. I'm afraid of cancer. My answer is that do not be afraid of that, because it is not going to happen, because the dosage of radiation that one receives from PET scan or CAT scan, it is within safety range. One doesn't have to worry about that. Okay, this is the established cause of cancer. Today, I would say I have 260 slides. It's a lot. So some slides I may just go through quickly, because some I don't think I need, I want to waste time. You can go back to you yourself if you are interested. I will concentrate in more clinical-oriented presentation, if you don't mind. Now, second slide is just for you to know some terms. Oh, by the way, I don't know if any of you medical doctor and board. If you do, please bear with me, even though maybe you have heard of that. However, I don't think oncology is very common among medical doctor as well, because in my practice, some medical doctor even have the phobia about oncology. So please forgive me of that. And I really have to give a compliment to all the participants today, because I really admire your courage to take the challenge of learning some oncology aspect, clinical management, and it is not an easy task. And so please bear with me. I have a lot of information, and you don't have to remember everything, because I don't expect you to. And just kind of listen to me telling you stories, and you can always go back to the details if you like to. Okay, this slide just shows you some terms you know. The oncogene, which means promotes cell to create cancer. Tumor suppression, as name implies, it slows down the tumor division. And DNA repair genes which repair the DNA. You just have to know those names. That's really no clinical importance. It is for researchers. So now, when we talk about malignancies, now, basically in hematology oncology, we divide it into two parts. One is hematologic malignancy, which is mainly deal with leukemias, lymphoma, and multiple myeloma. And as compared to solid tumors, which are, let's say, lung cancer, breast cancer, and so on, those are solid tumors. And hematologic malignancies, usually we have a hematologist to deal with that. And solid tumor, usually is oncologists to deal with that. However, in oncology training, they also have to learn hematology malignancy as well. Just they don't know the full scale hematology itself. So they are not, usually when you see hematology oncologists, they always have combined training in both. Okay, I'm going to go through quickly so category of hematology malignancies. Leukemias, as you know, it implies lymphoma, multiple myeloma, and for those who are not familiar with medical terminology, Western medical terminology, I'll help you with this. Leukemia means white blood. Mias, M-I-S is blood. Leuke is white. Lymphoma, Mars, usually means tumor, being benign or is a solid growth. So lymphoma. And multiple myeloma implies multiple, meaning many areas. Myelo, it means bone marrow. Mar, meaning forming of growth. So multiple myeloma means the malignant growth inside the bone marrow in many areas. Okay, so basic consideration, basic function I have to introduce to you so you have a better idea why bone marrow is also important. Because bone marrow produces red blood cell, which includes red blood cell, white blood cell, and platelets. And function of these cells is that, okay. Bone marrow produces white blood cell. White blood cell basically is for defense, and the lifespan is 12 to 17 days. And red blood cell deliver oxygen. The function of the red blood cell deliver oxygen to tissues, and lifespan is 120 days. And platelet forms a black clot to stop bleeding. Lifespan is about 7 to 10 days. Now, the importance here is that I would like to emphasize, go back to the first slide when I said lifespan uncontrollably grow by tumor. This shows you normal cell has lifespan. White blood cell red blood cell, platelet have lifespan, they die. And when they die, they go to spleen, which is organ in the left upper corner abdomen, and that will absorb all this debris. And then spleen is very important function. So this to show you. Now this is just the image to show you how bone marrow is done, which I used to do. I've done thousands of them already. And person will bend, lay down on the stomach in prone position, and after local anesthesia, the needle. Okay, let me see. Let me go. I'm sorry. Okay. Okay, the needle go down into the posterior iliac crest to we go aspirate the blood from bone marrow from the blood from the marrow, and that blood will be sent to a lab. I will make the slide smear, stain it, and look at it under microscope. And also at the same time, biopsy will be taken inside the bone marrow. And this is bone marrow anatomy of bone marrow. For example, this is femur. And the cross section, you can see inside the marrow, these are the area. Usually I explain to the patient as it is a blood factory. Literally it is. It produces blood cell, red blood cell, white blood cell, and platelets. Now, let me see what time, let me see. Okay, this is a peripheral smear, which we did a finger stick and put the smear on the slides and we stain them. And as you can see, this is red blood cell. Red blood cells are white with paler in the center. It's kind of a donut shape. And then this white blood cell, we call it band. And then when it gets mature, it becomes more nucleus, becomes three lobules we call poly. And this is eosinophil, because the stain turned red color, we call eosinophil. And this is basophil, the dark granules. And the importance here is the eosinophil usually shows up when the person has allergic reaction. For example, hay fever or any allergic reaction, or sometimes in parasite infection, you can increase eosinophil. Now, pay attention to this thing. This is platelet, so small, okay? And one wonder, how can they form the blood clot? Our body is a wonderful machine, automatic machine. What happens is that when a person gets injured, and normally body tissue would release the fibrin, we call fibrin, is in the serum, in the blood itself. It will form the network. And this platelet will naturally be drawn to the network to form a clot, to plug the hole, to stop the bleeding. That's how body works. And this is just the explanation as to how bone marrow is being formed. We call hematopoiesis. And this is top on the cell, stem cell in the bone marrow. And it would divide into two parts. One is myeloid, and to the right is lymphoid, two systems. And from lymphoid, the progenitor will mature into lymphoblast. And lymphoblast will move further mature into B cell and T cell and natural killer cells. So the importance is that B cell is the one we know produce immunoglobulin, which fight against any kind of infection or for immune system. And T cell is a little bit different. It forms a cell, it becomes an attacker to the invaders. So its cell will go attack the cell, attack the invader, virus or bacteria. So two different functions. We call this humoral immunity, meaning they secretes immunoglobulin, which is humor, the fluid. And this is a cellular, which the cell itself attack the invaders. And natural killer cell, name implies it kills whatever comes in. So this is lymphatic system. Now we'll go to myeloid system. Myeloid system is divided into three parts. Again, it's a red blood cell and myeloblasts and platelets. So red blood cell will stop there. Platelets will stop there. However, myeloblasts will go further down, divided into monocytes, basophil, eosinophil, neutrophil. All these are called white blood cell. So when we say leukemia, we talk about white blood cell. However, we have leukemia that involves red blood cell. We have increased platelet production we call erythrocythemia. I mean the thrombocythemia. That's another malignancy, which I will explain later. So these are the main concept of how body produces blood cell in different aspects. Now, this is important for you to understand, try to visualize. This is the image of blood tube. It's painted down. So you can see the top portion is plasma, 55% of plasma. And less than 1% of total blood is leukocyte, we call Buffy coat, which contains leukocyte and platelets. And this erythrocyte, this red blood cell. So the reason why I say transfusion is for you to understand, of course, if you're in the hospital practice, then you're more familiar with this. However, I think probably you guys don't have the opportunity, so I'd like to explain to you how the real life functions there in hospital. Now, when we can transfusion, we always mean PEC cell, meaning red blood cell only, this part only. And when person has excessive bleeding, we consider some coagulation problem, we transfuse plasma, okay, plasma. And here, this little section, leukocyte and platelets, will further be divided and separated into a platelet transfusion, okay? And a PEC cell, I'm sorry, this is so sensitive, sorry. Okay, if you see on top PEC cell RBC, that's usually form of transfusion. And in blood bank, it says only good for 6 weeks. And platelet shelf life is only 5 days because, as you know, platelet is lifespan in the cell 7 to 12 days, so lifespan very short. And plasma, because there's no cell involved, only plasma, so it can last longer, about 1 year. There's no WBC transfusion. The reason is because white blood cell has a lot of antigen on top of the white blood cell, and it can cause a severe allergic reaction. So nobody transfuses white blood cell, and that's the reason. Now, when you get to transfusion, something maybe you want to know about is transfusion reaction can happen. It doesn't happen immediately. It only happens after the person has repeated transfusions for many, many times. And normal life, you don't really have that. It will happen only in person with sickle cell anemia, which require frequent transfusion. And after a while, they may develop antibody to the donor blood after a while. However, it's not common either because usually when you do the blood transfusion, we do type and cross match. That means type A, type B, O, they all match properly. And the process is that we draw the blood from the patient, and that specimen we send to a lab to cross-match with the donor blood in the lab. Make sure they don't agglutinate, meaning don't form the clot. Because if they form the clot, that means it's not compatible. So that thing will be done in the lab. And so transfusion reaction will be minimized to the way you want. So now you know this transfusion. This is something for you to know about. As a matter of fact, as I said, I like to bring the clinical practices to you so you have meta idea as to what happened to you. And like I said, maybe many of you don't have the opportunity to work in a hospital setting, so you may not be familiar with this. Okay, this is I found interesting because I did hematology. I used to go to a lab a lot, and I see blood tube for different purposes. And this is a blood tube. You know what that white is? It's a fat. Normally, it should be yellowish translucent fluid. And this tube has all the fat and called hyperlipidemia. This is extreme case, of course. Some fat only halfway, and that is totally fat. And this made me think of one thing, very interesting, TCM related. And as you know, TCM talk about stroke or heart attack, you talk about phlegm. And this I consider this a Western concept of phlegm is all about. I hope this will help you to understand TCM phlegm, what it means. This gel-like. Okay, now go to, okay, now let me see the time. I have to control time, excuse me, 11:30, 30. Next one. Okay, good, I don't have to rush. Okay, leukemia means increased growth of white blood cell. Of course, those are abnormal white blood cells. Erythrocythemia, which in the formal term is polycythemia vera, which means increased growth of red blood cells, which again, abnormal red blood cells. Thrombocythemia, which means increased platelet. All these are, and multiple myeloma, increased plasma cell. All these are abnormal cells. Because sometimes people ask me, for those erythrocythemia, too much blood cell, or too much red blood cell, why don't you donate the blood to others? No, you don't want to donate malignant blood to anybody. So kill that thought. All right, this is another slide for bone marrow. So I try to give you some visualization of what blood looks like. This is platelet, so small. Look at so small. And this is RBC, and this is WBC. Okay. And this shows you increased white blood cell as you compare to the previous slide. Only few white blood cell, and this is too many white blood cell. And you see, and also you can see red blood cells look abnormal. They are not normal red blood cell. You can tell that. And this is what multiple myeloma looks like. Again, this has to show you it's produced from the bone marrow, and this look very nice and cute, but actually they are very malignant. They are not cute at all in real life. And this bone marrow, this is another image to show you that normal blood cell will be like this, and this one shows you so many white blood cells. And what happens is that when you have so many white blood cells, it interferes with the circulation, number one. Number two, because the bone marrow produces abnormal white blood cell, it takes away the production of normal cells, which means because abnormal white blood cell has been produced, so normal red blood cell, normal platelet count will be suppressed because of this abnormal pathology. So there are two types of leukemia, which is myelocytic and lymphocytic, as I said to you, the two types of white blood cell. So erythrocythemia, I'm going to touch upon it quickly. It's a myeloproliferative disorder. It's hemoglobin greater than 16.5 and hematocrit greater than 49%. And this another kind of erythrocythemia, which we call secondary, and usually caused by COPD, which means chronic obstructive pulmonary disease. And it happens to chronic long-standing smokers. They have emphysema to that extent. And what happens is that when the body go to that extent, become hypoxic, and the hypoxic stimulate the body to produce more red blood cell. And so those who have a healthy kidney will produce enough erythropoietin and help produce more red blood cell to carry oxygen. And it's a wonderful bodily compensatory mechanism. So again, I will mention to you that bone marrow produces too much red blood cell, causing increased blood viscosity, which we know in Western medicine. And this can coincide with what we call blastasis in TCM. Again, same thing, stroke and heart attack are the serious consequences because of increased too much blood. And in the situation of a polycythemia vera, the treatment is very simple. When we see the blood is so high, usually up about 55%, normal should be less than 49. So we do the blood test. When the hematocrit increase up to 55, and person will need the therapeutic phlebotomy, which means we put the blood, we draw the blood and drain the blood from the person. Usually drain one bag, which is 500 cc of blood, whole blood. And that blood will be discarded because they are not normal. You don't want to give to donation. And on the other hand, sometimes the person does not respond well to phlebotomy, then use chemotherapy. Basically, chemotherapy used in this situation is suppress bone marrow, not to produce more red blood cell. However, in the same token, when you suppress red blood cell, you also suppress white blood cell and platelets. So it's a double-edged sword. So it has to be monitored closely by hematologists as to what's the right dosage for chemotherapy to bring down the blood count. Okay. Now, next one, thrombocythemia, that is increased platelet count, abnormal platelet. And again, this is another case of blastasis in TCM, because too much platelet, it causes blood viscosity, and the result will be stroke or heart attack, which I've seen. I have a patient now, he seems exactly like this situation. He had too much platelet, and he had a stroke, and result in left hemiplegia. So this can coincide with the blastasis in TCM. And actually, back to this polycythemia vera, erythrocythemia. And I don't know if you've seen that, but this kind of patient usually face deep red face, and typical description of too much blood. And for this thrombocythemia, too much platelet, the treatment will be chemotherapy. You don't get the blood because platelet only consists of 1% of whole blood. So I don't know how much blood you got to drain it to decrease platelet. So a solution will be to use chemotherapy. Same thing. Chemotherapy suppress bone marrow production of all cell lines, which means we suppress platelet, also suppress white blood cell, or suppress red blood cell, or none. There's no selective. One medication can cause suppression of platelet only, does not exist. Okay. Okay, this is some image of Hodgkin lymphoma, which is very common around the neck area. It's the most common presentation. And just to show you some cutaneous T-cell lymphoma. Remember, as I told you, T-cell is a cellular defense mechanism. It's one of lymphocytes, T-cell. And this just to show you, it can present a skin condition like that. However, I don't want you to be misled by this picture. I say, oh, every time you see the skin lesion will be lymphoma. No, not all black and white stripes are zebra. Okay, so just to keep in mind, T-cell lymphoma can look like that. And typically in clinical setting, when a person has a skin condition treated by dermatologist, after a while does not respond, usually dermatology will do a skin biopsy to make sure it's not T-cell lymphoma. Okay, this is another image of lymphoma rash. That is not very common, but it can happen. So when you see skin rash, keep an open mind. Skin rash is not everything is eczema. Could be anything else. So keep an open mind. Okay, lymphoma, it means abnormal growth of lymph gland. And there are two types. One is Hodgkin lymphoma, one is non-Hodgkin lymphoma. Okay, now I will touch upon the multiple myeloma briefly here. It's abnormal growth plasma cell in the bone marrow. And symptoms usually present with bone pain, anemia, because it's inside the bone. And diagnosis is based on the bone marrow biopsy. You do the blood test, doesn't show much, or except you see high protein. However, the main diagnosis is based on bone marrow biopsy. I've shown how bone marrow biopsy is done usually at the hip. And treatment is chemotherapy. And this condition is a little bit tricky because it increases high protein. And if not treated, it causes increased blood viscosity. And that in Chinese medicine can equate to blood stasis, then cause increased risk of stroke or heart attack. However, common symptoms will bone pain. And in this situation, fracture is not uncommon. You can see fracture in the spine, rib, long bones, and pelvis, etc. And that can be very painful. And usually, bone pain from bone fracture is intense. And in this situation, I don't think acupuncture is a treatment choice to relieve pain here, because usually I will refer for radiation or chemotherapy, because bone pain is just fracture pain is just different. It cannot be managed with acupuncture. That's my experience, unless you guys have different experience. Okay, this is image under microscope. All the plasma cells, they look very cute, as a matter of fact, but they are very vicious. Again, this is a myeloma image. Now we're going to talk about solid tumor. Just an overview. I just want to give an overview. Cancer usually classified according to cell types and location of the tumor, such as basal cell carcinoma of skin, squamous cell carcinoma of anus, adenocarcinoma of colon, clear cell renal cell carcinoma, follicular cell of thyroid, small cell carcinoma of lung, etc. Now, terminology. Malignant tumor is carcinoma and it's cancer. Depends on what situation you use. Cancer is like a layman term. However, in medicine, we use carcinoma as the official name. Now, types of cancer by cell type. It has basal cell that usually is in the skin. Squamous cell you can see in skin, oral cavity, esophagus, cervix, anus. And adenocarcinoma usually in the GI tract, the mucous membrane, intestine, pancreas, gallbladder, which secretes some enzyme. And breast, you can see adeno because breast is secretory gland as well. Ovaries, of course, same thing. Uterus, same thing, mucus. Prostate has mucus. Lung has mucus. So all this you can see adenocarcinoma. However, next one, then you go to organs. And let me see. Okay, organs. And just to name, so you're familiar with that. Lung, small cell, squamous cell, adeno, different types. GI tract, mostly adeno, and sometimes the squamous cell is usually in the esophagus. And hepatocellular, that's liver, hepatoma. That's primary liver tumor. It's not, we're not talking about metastatic tumor to liver. No, it's a primary from liver. Thyroid cancer, you see medullary, papillary, Hürthle cell, follicular, anaplastic. Sarcoma, which means a tumor of the muscle and fibrous tissue, tendons, fat, and so on. Leiomyosarcoma, and so on and so forth. The kidneys is cancer because the kidneys has its own different cell type. So classified by clear cell or papillary or chromophore or unclassified. Bladder cancer, same thing, because the organ itself has transitional cell carcinoma, squamous cell. Brain tumor, which is quite scary. Meningioma usually means it's a membrane, meninges. It's a membrane cover the brain, which usually is benign. But however, when you grow bigger, become malignant, and they become aggressive, that cause symptom, then you may need surgery. And the astrocytoma, glioma, glioblastoma all can turn into malignant, which usually requires surgery with early stage. Soft tissue sarcoma, which means of soft tissue, muscle, skin, and this could be difficult as well. In different parts of the body, can happen in the hip, thigh, wherever, where muscle goes. So another term maybe you like to get yourself familiar with is what is well differentiated, poor differentiated. I know it's not in your business, not in your practice that you need to tell. However, when you see a cancer patient who tell you this, so if you understand, then makes you feel more comfortable in getting involved in this patient's care. So please bear with this, all right? And that's what I told my daughter, who's in the studying this last year in the Chinese medicine. I told her that don't be afraid to learn some Western medicine because that will help you. Because the more knowledge you have, the more you're confident in dealing with all kinds of situations. So do not reject Western medicine. That's what I told her. Learn, so be more confident. So where differentiated, it means it's a better type of cancer because it's well differentiated. It does not go into crazy aggressive form. However, when it comes to poor differentiated or undifferentiated, that means this cell can turn into any direction and usually more aggressive. Excuse me. So when you hear poor differentiated, well differentiated, you know, excuse me, what kind of cancer this person has some idea. And in the broad view, cancer among men and women, very interesting. Man is prostate, number one. Woman is breast, number one. However, number two and number three are the same. Lung and colon in men, so are lung and colon in women. And as you see, the statistics shows that men is prostate, lung, and colorectal accounts for 43%, and women of these three, 50%, and quite scary. Now, cancer metastasis. This is something I'd like to share with you my thought. And actually, this is a thought I challenge Western medicine. Okay. 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 Metastasis means cancer cell move from original site to another areas or organ in the body. However, in cancer, certain cancer have certain area they like to metastasize to. For example, lung likes to go to liver, bone, or brain. And breast like to go to liver, lung, or bone. Similarly, for kidney, they like to go to lungs, number one. And for prostate, usually they like to go to local area. So each cancer has different pattern of metastasis. And Western medicine still doesn't understand why it is like that. There's no explanation why certain cancer tend to go to certain area. There's no answer to that. However, there's postulated mechanism of cancer metastasis. That is by three ways. One is direct invasion to the surrounding tissue or organ, which is understandable local invasion. For example, prostate, we tend to invade locally in the prostate area, in the surrounding area. Urinary bladder, same thing. They tend to in the pelvic area, local. So pancreas, same thing, local invasion. Pancreas being location right next to duodenum, next to gallbladder, next to liver. So local invasion is understandable, and then go up. Pancreas go up through a diaphragm, go to lung, can go to lung. So consider direct invasion, local invasion. However, second form is transport, the cancer cell transport by bloodstream to distant organs everywhere. And another is by lymph transmission, which is very common as we see, excuse me, breast cancer. And that's why they do lymph node dissection in axillary area, because in the breast, which I'll describe later on, the lymphatic drainage of the breast can go to axillary. And that sometimes they can spread to the axillary area, armpit. And that's why they do lymph node dissection very frequently, which will result in lymphedema, which we discuss later when it comes to the section of breast cancer. So these are the three forms: direct invasion, distant metastasis, and this through the blood, and another one through lymph. Now, the question I have here, maybe you guys can think about it. See, that's why I said just now, colon to liver, kidney to lung, and then lung to bones, okay? This is in this order: frequency of distant metastasis, lung transfer to bones, more common than brain, and in that order. So why bone first? Why not brain? And colon, why not brain first? How the liver? And kidney, why not bones and go to lungs? So this is a question and answer. Now the question here is, I used to challenge some medical doctor. I guess nobody has an answer. Now I give this challenge to you. Since cancer can spread through the bloodstream, shouldn't we see all cancer spread to the heart? Why is there no such a thing as heart cancer? Anybody has the answer to that? Because as we know, our blood circulation starts from the heart. Heart pumps up to aorta, go down to whole body, and then return from venous system, from inferior vena cava to superior vena cava, and back to right heart, right atrium, then right ventricle, then pulmonary system, then left atrium, then left ventricle, then also aorta, then spread to whole system again. How come cancer cell doesn't go to heart? Interesting, isn't it? But I think I have answer to that. It's from TCM. So same thing. Another question is that in terms of metastasis, breast cancer can spread to liver, lung, and brain. But why don't we see lung cancer spread to breast? Or liver cancer spread to breast? No, never heard that. Why not? And this is a challenge to Western medicine. Now, review the TCM theory. Those who can read Chinese, please do that. I'll read in English. This is from Ling Su, chapter 71. The heart being the master of all zang and fu, it has a very strong structure which does not allow evil qi to enter. Therefore, when there's evil qi invasion, pericardium would absorb the insult. Okay, is that true? I investigated it. So this is according to statistics in Western medicine. Primary heart cancer is rare, only 0.01%, 0.2 to 0.1% on postmortem analysis. However, secondary, which means metastatic, not primary heart cancer, tumor to pericardium, myocardium, great vessel, is 0.7% to 3.5% autopsy. Again, compared to 0.01, is much lower. So in altogether, they found that the 64 to 69% of metastatic heart cancer involves pericardium. So TCM is right. Pericardium protects heart. Make sense? And the last sentence here, most metastases come from lungs, lymphoma, leukemia, melanoma, breast cancer, they all directly into the vicinity. Lymphoma, you know what lymphoma? Lymphoma can happen in the mediastinum, meaning in the middle of the heart, of the chest, between two lungs. That's mediastinum, around trachea area. And that's right next to the heart. So immediate invasion. And breast cancer also right in front of the heart. You can go directly there. Melanoma is very tricky, okay? Now, so let me see, where are we now? Okay. Okay, now, how cancer is diagnosed? As I said, you guys may not be involved in this process. However, it's good for you to know how things are going and make you feel more comfortable, familiar with cancer patients. Of course, our signs and symptoms and blood tests, endoscopy, upper GI endoscopy to see any stomach cancer. Bronchoscopy would try to diagnose lung cancer, do the biopsy, and can X-ray for chest or CAT scan the abdomen to see any lymph node, to see any liver enlargement or spleen or kidney tumor, PET scan, etc. However, the final diagnosis is based on tissue diagnosis, which usually means a biopsy, a specimen of tumor, examine under a microscope or other biochemical, biological techniques. So many times patients ask me, oh, what do you think this tumor is? I said, well, let's don't guess. Let's do a biopsy first, because sometimes you may be different from how they imagine. So I usually tell patients when they come to me, ask me, oh, I don't know this tumor, should I do this? What if this, what if that, what kind of cancer? I said, please don't guess what kind of cancer. Let's get to the bottom and then we discuss accordingly, because there's no point in guessing 100 possibilities and to know to be maybe none. So that's all you know. Okay, now stationary cancer may be something you'd like to know about. TNM system. T means tumor, size of tumor. N means node, lymph node involvement. M means metastasis. So it comes to TN, T1, N0, M0, and so on and so forth. And usually what it means, stage 1 usually is the earlier stage, easiest. And stage 4 usually most advanced and most bad, worst prognosis. And staging may vary from different type of cancer, which that you don't really have to get involved with. But just so you know, TMN system is staging. And treatment of cancer. And of course, normally, the surgery, chemotherapy, radiation therapy in general is like that. Now, I just go quickly, show you some outline of what management is all about. So surgery, of course, you cure with intent. That's understandable. When it's small in the early stage, you cut it and think you're okay. And then second one's palliative purpose. What does it mean by that? For example, when a person has a colon cancer that block the passage of the intestinal content, meaning the bowel movement doesn't move. However, on the other hand, this person also found to have metastasis in the liver. So in this case, by removing the section of tumor in the intestine does not achieve any curable intent. However, we still do it. It's for palliative, because you don't want person to suffer from obstruction of intestine. So that's called palliative purposes. Okay. So when sometimes people would ask, "Oh, is cancer resectable?" Of course, all resectable. Everything is resectable, according to one surgeon who told me, "You give me a knife, I'll cut everything for you." However, what is necessary? Is it safe? That's another story, and that will be determined by the surgeon on the spot. Because sometimes tumor cannot be killed by chemotherapy or radiation therapy. Keep in mind, not all tumors can respond to chemotherapy or radiation therapy. And I'll go quickly in general. What complication we can encounter in surgery? Are you guys still following? Is it too much for you? I hope not. I just listen to a story, okay? Now, usually surgeon would explain possible surgical complication. And depends on what area is cut, of course, as it's understandable. Depends what area. So for example, brain. The brain surgery, cut the brain, that will affect the outcome. Let's say, for example, become paralyzed one side, on the other, depends. It depends on what region brain is cut. Eye, yeah, it's not common. However, it can happen in melanoma in eye. You have to remove the whole eye. Inoculation, that remove the whole eye. Then, of course, we lose eyesight on one eye. And throat and tongue, which is not uncommon, we call head and neck cancer. It's cancer of tongue or throat, and do surgery. And the result is that person may have problem swallowing and may have problem in speaking or breathing, depends on the extent of the surgery that involved. And sometimes when you cut the throat and cannot swallow, then person has to tracheostomy, meaning put a hole in the throat, and through which person may be able to breathe or may be able to feed the tube down, the feeding tube. So that's a complication, or let's say expected result from the surgery. Thyroid is easy. What that is, you have to cut the thyroid. If thyroid is removed, and you have to give a thyroid supplement. And lungs, usually lung is not a big problem because usually lung is a lobectomy. Rarely see pneumonectomy, which means the whole lung removed, which is impractical because when in the case that which whole lung is involved, that means condition really grave, and you really no need to do extensive surgery to that extent. And breast surgery is very common, lumpectomy, mastectomy, and so on. And we discuss later. Stomach, of course, same thing. It depends on sometimes the extensive of the disease or the condition. You may have partial gastrectomy or total gastrectomy, and result will be affecting the intake, food intake, and then affecting digestive habits. Large intestine, same thing. We discussed when it comes to colon cancer, and some people may have colostomy, some people may not. And small intestine, which is not very common because small intestine cancer is usually not easy to diagnose, and usually it's not as often as colon cancer. And pancreas is not uncommon. We discussed when it comes to a separate section. Gallbladder, same thing we discuss later. Liver, kidney, with this bladder, uterus, we discuss later when it comes to each section. Okay, side effects of chemotherapy, which is most commonly that you're going to encounter. Probably, I guess many of you have treated cancer patients with these conditions. First of all, let's say leukemia, which is low blood count, thrombocytopenia, low platelet count, anemia, low white blood cell, and no RBC, peripheral neuropathy, which means numbness of the tingling of fingers and toes, and breathing problem that could be caused by some chemotherapy. And the cardiomyopathy can be caused by adriamycin, which is usually very frequently used in breast cancer and colon and ovarian cancer as well. And anemia, leukemia and lymphoma use that a lot too. Nephrotoxicity, kidney involvement, alopecia, hair loss, liver toxicity. It can happen. Nausea, vomiting is most common. It's nausea, vomiting. Skin rash that can happen in certain medicine, especially immunotherapy. And fatigue is a common symptom among all patients. And I guess many of you must have this experience treating a patient like this. Now, I got to emphasize more breathing. Leukopenia. Okay, leukopenia. Okay. Okay, what's important here is that patient who is getting chemotherapy frequently experience leukopenia. And usually leukopenia blood count drop, usually go to the bottom at 12 days after the chemotherapy, usually. And thanks to modern technology and invention of pharmaceutical company, now they have the medication to bring our white blood cell count, so that makes it easier. However, I don't know if you have treat anybody with leukopenia, patient who is undergoing chemotherapy. Usually, I do not treat patients like that when they're under active chemotherapy, because I don't want to complicate the picture that they're getting chemotherapy, and with leukopenia, they're getting treatment medication, and I don't want to be involved with that. And that will ease up the anxiety of patient, as well as, even though I'm an oncologist myself, I know how oncologists think. They don't want to be disturbed by their treating course. So I usually tell patient, you have leukopenia, stick with oncologist, go through that first, and I'll keep my hands off I don't do that. Now, another frequent condition is thrombocytopenia, which is very practical because platelet count drop, you can have tendency in increase the risk to bleed, and you don't want to create that problem. Same thing. I usually when person is under active chemotherapy, I usually don't treat patient of that kind because I don't want to complicate the situation, create more trouble for patient. So I usually don't treat them with the acupuncture. And of course, less than 50,000 have the increased risk of bleeding. I know many of them may not be that low. When you get to 30, then really have to be nervous. If a platelet count 30,000, we go by 30,000, 50,000. Normally it's 150 to 400. So when you're below 30,000, and that spontaneous bleeding can happen. So keep in mind, don't fool around with that, okay? Less than 30, patient can bleed, and you don't want that trouble in your hands. And usually, of course, low platelet count person can present with bruises and petechia, which is pinpoint size of red dots on skin, and bleeding from gum and nose, and blood in urine and stool, which are extreme case. But thank God, nowadays they have this medication can increase the platelet count, so you're off the hook. Like I said, person under active chemotherapy, I usually don't get involved in treating acupuncture, because I don't want to cause any unnecessary anxiety for the patient and for the oncologist either. So this is petechia, you see, small pinpoint dots. Okay, anemia is a low red blood cell. And then in case of that, of course, transfusion is the easiest way. And sometimes a person may receive medication, which means Epigen or Procrit. These two are the same medication. And this is a medication that increases bone marrow production of red blood cell only. And it's increased red blood cell, not white blood cell, okay? So now, touch upon this TCM. So Su in chapter 5 says, kidney generate bone marrow. Kidney is connected with the ear. So in Western medicine practice, we know for fact, person with chronic renal failure, especially those who need dialysis, they frequently anemic. That only validate Chinese medicine. TCM is right. Kidney generates bone marrow, correct? And also one step further, what does kidney do? Because there's one enzyme, one substance called erythropoietin. It's a glycoprotein secreted mainly by the kidneys, and which is responsible to stimulate bone marrow to produce red blood cell. Again, TCM score 1, correct. Kidney generate bone marrow. And again, with this understanding, then we understand why chemotherapy creates blood cell depletion, because it hurts kidney. Chemotherapy hurts kidney, TCM kidney. Is it clear to you now? Interesting, right? And let me see. Let me see. It's 50. Okay, I think I lost some slides. Okay. Some messed up with slides here. I'm sorry. Okay, I'm going to talk about a little bit more kidney toxicity. These are the names that you may or may not be here, but so you know, this a chemotherapy agent that can cause kidney toxicity. Cytoxan, very commonly used. Methotrexate in cancer patients are used a lot, and sometimes you can hear patients with the rheumatoid arthritis that using methotrexate. However, don't worry about that, because the dose of methotrexate used on rheumatoid arthritis is very minimum. It should not cause any kidney toxicity. Now, vincristine is used very commonly used. Daunorubicin, all these are commonly used chemotherapy agent in leukemia, lymphoma, breast, and so on and so forth. So kidney toxicity is very frequent. Now, ototoxicity, same thing. Again, remember we said Chinese TCM said the kidney connect with the ear. So here we go. This chemotherapy that affects ear. And this one, platinum, also affects kidney, affects both kidney and ear. This, again, prove TCM knows what they're talking about. Okay. Okay, so let's. Okay, here. In Western medicine, we notice that chronic kidney insufficiency patients tend to present impaired hearing. And as you know, in TCM also mentioned that when kidney gene is low, it affects ear. Hearing is a problem. Okay. Now, next thing is very interesting thing I found out from one of my patients who is a pediatric nephrologist. She told me that when they saw per newborn with the abnormal ear, they usually do a kidney ultrasound because that's linked with congenital kidney anomalies. Interesting, isn't it? Again, proven TCM knows what they're talking about. Alopecia, which happens in chemotherapy. But it doesn't happen right away. It usually happens about a few weeks after chemotherapy, and some has more severe than others. But usually it will grow back, irreversible. It is reversible. After a few months of chemotherapy stop, it'll grow back. However, hair loss in the case of radiation to the head is permanent because that radiation effect damaged the hair follicle for good. There's no return, okay? So this, again, chapter 9, Suwon, it says kidney gene is abundant, it promotes the hair growth of hair. And it only happens in the chemotherapy case. In radiation to the head, it's not going to happen because hair follicles are totally destroyed. Nausea, vomiting. A second. Okay. Nausea, vomiting, which is very common. And this, I really cannot find a connection with TCM because you know why? Because patients become nauseous maybe the same day with chemotherapy, which I don't believe is a direct relationship to kidney, liver, stomach right away. I tend to believe this make more sense in Western medicine. They consider is due to chemoreceptor trigger zone was activated by chemotherapeutic agents. Okay, now it's a long story. Of course, a lot of things to involve, and not every chemotherapeutic agent affects same manners. And some chemotherapeutic agents may be more nauseating than others, some are less. For example, a very strong one, adriamycin, which is red, looks very nice, is very commonly used in breast cancer, ovarian cancer, leukemia, lymphoma. That's very nauseating. Yeah. And some other, like say, methotrexate, which also used in many conditions, lung, head and neck cancer, ovarian, breast, that is not so nauseating. So it really cannot generalize as a kidney suppression or what. I tend to think that maybe chemoreceptor trigger zone is activated. And fatigue is very common, of course, fatigue. And of course, chemotherapy itself is very stressful. And let me look at time. Okay. All right. And like I say, if you treat those patients, you know, they're all very much emotionally challenged because chemotherapy is very stressful, physically, emotionally exhausted. And in the long term, they all present with kidney deficiency. However, on the other hand, you may have young in excess caused by some chemotherapy agents such as steroid, and radiation can make a person very hot as well and cause fatigue. Right? And I just want to emphasize here, I'm not trying to teach TCM here. I'm in no position for that. I just try to integrate East and West together. Hope to give you some information. You can integrate two together. I think we can take a break now. And during the break, I'll read those questions that you have. And I will read those questions you have and answer you in the beginning of next session. Okay? And maybe we can break now.